On this channel, I talk a lot about cholesterol and heart risk. A common question I get in the comments is, do you take a statin? I do understand why that question comes up. It can feel reassuring to know what a nurse or another type of health professional has personally decided to do. But I want to start this video by saying as clearly as I can, whether or not I take a statin should not be the deciding factor for you. Taking a statin is a personal medical decision. It depends on your body, your lab results, your family history, your other conditions, and how you feel about medication and risk. It is a decision made between you and your doctor or other healthcare provider based on your situation and your preferences. None of that should be based on what I do or what your neighbor does or what someone else online is doing. In this video, I want to give you knowledge so that you can participate in that decision in an informed way. I'm going to be talking about low-density lipoprotein, which most of us call LDL. LDL on your lab report refers to that number that reflects how much LDL cholesterol is circulating in your bloodstream. There is a lot of noise and confusion on the internet about LDL. Some people say LDL does not cause heart disease. Some say only inflammation matters. Some people say as long as triglycerides are low, LDL can be ignored. I've spent a lot of time reading those arguments and then going back to the original studies that they referenced. And when I follow the trail, I see a pattern of misreading or misrepresenting what the research actually found. From the overall body of evidence we have, too much LDL in the blood is clearly a real risk factor for cardiovascular disease. It is probably not the only factor, and I personally believe that heart disease is a complex interplay of many things that we do not fully understand yet. But LDL is definitely part of the picture, and pretending that it does not matter does a lot of people a disservice. Now, your body absolutely does need cholesterol. It is involved in many important functions in the body. The problem comes when there is too much LDL circulating in the bloodstream for too long. That is when it can start to build up in the artery walls and contribute to plaque. I will also be placing LDL in context. Triglycerides matter. Inflammation and oxidative stress matter. Movement, stress levels, blood sugar, blood pressure, and sleep all matter. I already have videos that go into triglycerides and oxidative stress, and I'll put links to those in the video description for anyone who wants a deeper dive into those topics. But recognizing all of those other pieces does not erase the role of LDL. They are all parts of the same story. I will also be going over lifestyle because I do believe lifestyle deserves to be the foundation before we get to statins or supplements or other cholesterol lowering medications in most situations. I also know as a nurse and as someone who has been around healthcare for a long time that lifestyle change is much more complicated than just being told to eat better and move more. Many people are just handed a printout and a prescription and sent on their way, and are not given any real tools for changing their habits, even when they genuinely want to. That is something that I care deeply about, and a big reason why I am building a membership focused on lifestyle support to help people meet their health goals. If you're interested in learning more about that, I will put a link to sign up for announcements in the video description. In this video, though, I'm going to stay focused on helping you understand LDL and statins well enough to make a thoughtful decision with your clinician. My goal is to give you a clearer sense of what LDL actually is, how it fits in the heart risk, what the research says about lowering it, what we know about statin benefits and side effects, and how to have a more confident conversation with your doctor about your options. I am not here to push you toward a statin or away from one. I am here to help you get enough context so that when you do make a decision, it feels like your decision based on real information and aligned with your values. I have a lot of information to cover, so let's get started. LDL is a term that gets thrown around a lot, so I want to make sure we are talking about the same thing. On your lab report, you will usually see a line that says LDL, or it might say LDL-C, or they could just write it out as low density lipoprotein. So that is measuring how much LDL cholesterol is circulating in your blood. When people say bad cholesterol, they are usually talking about this LDL number. When your doctor says that your LDL or your bad cholesterol is high, the concern is not that that cholesterol in itself is evil. The concern is that too many LDL particles are circulating in the bloodstream. Over years, those particles can work their way into the inner lining of artery walls. This is where the trouble starts. The LDL cholesterol that gets into the wall can get stuck, become oxidized, and trigger an inflammatory response. Your immune system sends in cells to clean up, and over time, that process builds up into a fatty, fibrous plaque. That slow buildup of plaque in the arteries is called atherosclerosis. It is the underlying process that leads to many heart attacks, strokes, and also problems with blood flow to the legs. Multiple lines of research tell us that people with higher LDL levels over their lifetime have more plaque and more cardiovascular events. People who are born with genetically low LDL tend to have much lower rates of heart disease. In imaging studies where we actually look at the artery walls, when LDL is pushed very low with treatment, plaques can stabilize and even shrink a little on average. When LDL stays higher, those plaques tend to grow. I also want to point out something I see a lot of people get confused about. A lot of the cholesterol doesn't matter talk online comes from mixing up two different things. More recent research has shown that the cholesterol we get from food does not raise cholesterol in the blood as much as we once thought. That part is true, but that does not mean that cholesterol in the blood, and especially LDL, does not matter anymore. When I am talking about LDL here, I am talking about the LDL in your blood, not the cholesterol in your food. And LDL still most definitely matters in the health picture. Another area of confusion comes from focusing on good versus bad cholesterol in a very simplified way. HDL, the so-called good cholesterol, is still important, but large studies consistently show that the strongest, most reliable relationship to heart events is with LDL. The higher the LDL and the longer it stays high, the higher the risk. That is why major guidelines around the world make LDL the primary target for preventing atherosclerotic cardiovascular disease. You might have also heard people argue that LDL does not really matter if your triglycerides are low, or if your inflammation is low, or if you eat in a certain way. I understand why those arguments are tempting. It would be nice if one lab number could just be ignored. When researchers look carefully at the data, though, a different pattern shows up. Even after accounting for things like HDL, triglycerides, blood sugar, blood pressure, LDL still carries its own independent relationship with heart risk. It is one piece of a large puzzle, but it is not a piece that we can just erase. At the same time, LDL is not the whole story. Many people with elevated LDL never have a heart attack, and some people with normal LDL do. That is where the rest of your risk profile comes in. Your age, your sex, blood pressure, smoking, diabetes, kidney function, family history, and other markers like lipoprotein A. Those factors can change how worrisome, in particular, LDL numbers is for you personally. An LDL of 110 in a 30-year-old non-smoker with no other issues is a whole different situation than an LDL of 110 in a 60-year-old with diabetes and a high lipoprotein A. The number is the same, but the context is not. When people first see a high LDL on their lab report, it is very easy to just focus in on that one number. LDL does matter, as I just talked about. At the same time, your heart and blood vessels are responding to the whole environment inside your body, and not just a single cholesterol number on a printout. Cholesterol is just one part of a broader risk picture. On that same lab report, you will probably see triglycerides and HDL. Triglycerides are another type of fat in the blood. When triglycerides are high, that often tells us there is extra energy floating around that has not been stored properly. It can go along with insulin resistance, fatty liver, and a tendency toward higher blood sugar. HDL is often called the good cholesterol, and people with higher HDL levels tend to, on average, have lower heart risk. But what we see over and over in studies is that LDL still has the strongest, most consistent relationship with heart attacks and strokes. That is why doctors focus so much on bringing LDL down, even while they keep an eye on those other numbers. Beyond cholesterol, there are other forces quietly shaping risk in the background. High blood pressure puts extra mechanical stress on artery walls. High blood sugar and insulin resistance can damage the lining of blood vessels and make LDL more likely to cause trouble once it enters the wall. Extra abdominal fat, sleep apnea, and hormonal changes all feed into the same process. When several of these are present together, they amplify one another. An LDL that might have been borderline in a very healthy body can become much more concerning in the setting of high blood pressure, diabetes, or chronic kidney disease. Inflammation and oxidative stress are another layer. In simple terms, oxidative stress is an imbalance between rusting forces and your body's antioxidant anti-rust defenses. When LDL particles get into the artery wall and are exposed to a lot of oxidative stress, they can become oxidized LDL. Oxidized LDL is more irritating to the immune system and more likely to drive that chronic smoldering inflammation inside of plaque. Inflammation itself is not always bad. Acute inflammation is a part of normal healing. But in the artery wall, ongoing, chronic, low-grade inflammation can keep plaques active and unstable. This is part of why two people with similar LDL levels can have very different plaque behavior and different outcomes. Lifestyle patterns lie underneath many of these risk factors. A pattern of eating that is heavy in ultra-processed foods, added sugars, and trans fats tend to push triglycerides up, worsen insulin resistance, and nudge LDL in the wrong direction for many people. A pattern that emphasizes vegetables, fruits, fiber, beans, nuts, and healthy fats tends to move things the other way and support healthier blood pressure, blood sugar, and cholesterol. Regular movement improves insulin sensitivity, lowers blood pressure, and has favorable effects on triglycerides and HDL. Chronic stress, poor sleep, and smoking all pull in the opposite direction and increase overall cardiovascular risk. None of these act in isolation. They create a setting where LDL either does more damage or less. I want to acknowledge something else that comes up a lot. Some people are told that their LDL is high and immediately feel blamed, as if every point on that number is a moral failure. Others swing to the opposite extreme and say, my lifestyle is great, so my LDL cannot matter. The reality is a little bit more complex than that. Genetics, hormones, aging, and other conditions can all influence LDL, sometimes quite strongly, even in people who are doing many things right. At the same time, lifestyle still has real power to shift the overall risk picture, even if it does not bring LDL all the way into the ideal range on its own. It is not all your fault, and it is not completely out of your hands either. Two people with the exact same LDL can have very different recommendations from their doctors. If someone is young, they don't smoke, has normal blood pressure and blood sugar, and has no major family history, a mildly elevated LDL may lead to just a focus on lifestyle and monitoring. Now, if there's someone else who is older, already has plaques seen on a scan, has high blood pressure, or has something like diabetes, the same LDL level carries a higher risk in context, and medication comes onto the table much sooner. LDL is still part of the story in both of these cases, but it is interpreted through the lens of everything else going on in the body. So when you look at your own labs, try to see them as one part of the whole environment your arteries are living in. LDL is one important signal, but so are triglycerides, blood pressure, blood sugar, weight, smoking status, stress level, sleep, and family history. As we move forward, we will be talking about how doctors pull all of those pieces together to estimate your actual risk of a heart attack or stroke, and how that risk estimate helps shape the statin conversation. In good care, decisions about statins are based on your overall heart risk, not just on whether one lab value is flagged as high. Healthcare providers look at the whole picture of your health and then decide which tools, including lifestyle changes and possibly medication, might help lower the chance of a heart attack or stroke over time. LDL is a key part of that picture, but it is only one of the several factors that should be considered before anyone reaches for a prescription pad. Your doctor should be using the idea of absolute risk. This is usually used in the form of a calculator. Absolute risk is an estimate of, out of 100 people like you, how many are likely to have a heart event over the next 10 years. That like you part includes your age, your sex, blood pressure, smoking status, other cholesterol values, and sometimes things like diabetes, kidney disease, and other conditions. Different countries and different organizations have slightly different risk calculators, but they all try to pull these pieces together into one number that helps guide decisions. Age ends up having a big influence on this because plaque builds up over time. A 35-year-old with moderately high LDL and no other major risk factors may still have a relatively low 10-year risk. The same LDL level in a 65-year-old with high blood pressure often translates to a much higher 10-year risk, even if that older person feels pretty well day to day. This is one reason some people are surprised when their doctor comes more concerned about their cholesterol as they get older, even if the numbers have not changed very much. There is also an important difference between primary prevention and secondary prevention. Primary prevention is when you have not yet had a heart attack, stroke, or procedure like a stent or bypass. Secondary prevention is when you already have known cardiovascular disease. In secondary prevention, the bar for treatment is much lower because we already know plaque is present and that it has caused trouble. In that setting, there is very strong evidence that lowering LDL with statins and sometimes additional medications reduces the chance of another event. In primary prevention, when we are trying to prevent the first event, the risk-benefit balance is more individualized. Many guidelines use broad categories like low risk, borderline risk, intermediate risk, and high risk. If your estimated 10-year risk is quite low, your doctor might suggest focusing on lifestyle, keeping an eye on things, and repeating labs after some time. If your risk is intermediate, that is often where a more detailed conversation happens. Can lifestyle alone reasonably bring this risk down? Are there additional risk factors that the basic calculator might not fully capture? In a high-risk range, especially if you also have conditions like diabetes or chronic kidney disease, medications like statins are strongly recommended because the potential benefits are larger. Another layer on top of the basic calculator is what we call risk enhancers. These are factors that may not be fully captured in the traditional formulas, but still shift the balance. Examples include a strong family history of early heart disease, chronic inflammatory diseases, certain pregnancy complications in the past, metabolic syndrome, chronic kidney disease, and elevated lipoprotein A. When one or more of these are present, many doctors will lean towards more intensive LDL lowering at a given calculated risk level because your true underlying risk is probably higher than the basic equation suggests. Sometimes imaging is used to refine risk further. A coronary artery calcium score, for example, is a CT scan that looks for calcified plaque in the heart arteries. A score of 0 can be reassuring in some situations and might support a more conservative approach if everything else looks favorable. A higher score tells us that plaque is already present and often pushes the discussion more towards statins and other treatments, even if the LDL does not look extremely high. This is not something everyone needs, but it can be useful in gray area cases where the decision is not clear from labs and history alone. All of this is why two people can look at their LDL numbers and feel confused when they get very different recommendations. One person with an LDL in the 90s and low overall risk might be encouraged to keep working on nutrition and movement with no medication for now. Another person with the same LDL in the setting of diabetes, high blood pressure, and elevated lipoprotein A might have a very strong recommendation to start or intensify statin therapy. The number on the page is the same, but the background risk is not. If you have never had a conversation with your doctor that includes your actual 10-year or lifetime risk estimate, it is reasonable to ask for that. Knowing your risk in numbers can make the statin decision feel less like guesswork and more like a thoughtful choice about how much risk reduction you are aiming for and what tools you are willing to use to get there. A lot of my viewers have found me through my videos about lipoprotein A, so I want to take a minute to specifically address that. In an ideal world, people with high lipoprotein A would have their risk treated differently. But in reality, many doctors do not routinely test for lipoprotein A, and even when it is checked, some are not fully sure how to interpret it or how it changes the overall risk picture. I have experienced this personally with my own doctors. So if you feel like you know more about lipoprotein A than your doctor does, you are in good company. Lipoprotein A looks very similar to LDL, but with an extra protein attached to it. That small change makes a big difference in how it behaves. High lipoprotein A is linked to more plaque in the arteries and a higher risk of heart attack and stroke, even when LDL is not extremely high. It is strongly genetic, which means people are usually born with a certain baseline level. Nutrition and lifestyle have only a modest effect on it compared to LDL or triglycerides. That is part of why lipoprotein A deserves special attention. People can have higher risk written into their genes without it showing up clearly on their routine cholesterol panels. Because lipoprotein A is not part of the standard lipo panel, testing often gets missed. Many doctors only vaguely know about it, if at all, and guidelines have only more recently emphasized its importance as a risk enhancer. That leads to a very common scenario. A person has high lipoprotein A, but the doctor looks only at LDL and says, your numbers are okay. Or they recommend the same approach that they would for someone without that added risk. From a risk standpoint, that person really should be treated more like someone with a stronger family history or another major risk factor. When lipoprotein A is elevated, the baseline risk of plaque and cardiac events rises, even if everything else looks average. That is why some experts aim for a lower LDL target in people with high lipoprotein A. The thought process is simple. If one type of cholesterol related particle is high and hard to change, it makes sense to reduce the overall burden by bringing LDL down more aggressively. On the surface, an LDL of 90 might look fine, but in the context of high lipoprotein A, that same LDL may no longer be reassuring. This is often why people with high lipoprotein A hear their doctor say that they would still like your LDL lower than it is, even if it looks normal on that lab report. Right now, we do not have a widely available, easy to use medication that directly and specifically lowers lipoprotein A in a way that has been fully proven to reduce events. There are promising therapies in development, and some existing treatments can lower lipoprotein A to a degree in certain people, but most day-to-day care still leans on tools that mainly affect LDL and other risk factors. That means the practical approach for many people with a high lipoprotein A is to treat it like a warning sign, and then work hard on the parts of the risk profile that can be modified more reliably, like LDL, blood pressure, blood sugar, diet, smoking, and other lifestyle patterns. Because so many clinicians are still getting up to speed on lipoprotein A, you may need to be the one to bring it up into the conversation. If you have never been tested, it is reasonable to ask if you can have your lipoprotein A checked at least once so you know where you stand. And if you already know that yours is high, it is reasonable to ask if that is being factored into your target LDL. These questions are not confrontational. They are simply asking your care team to factor in a piece of information that matters for you. Hearing that your lipoprotein A is high can feel unfair because it is not something that you caused and not something that you can fix with good behavior. Believe me, I know. But at the same time, knowing about it does give you a chance to approach prevention more intentionally. You cannot rewrite your genes, but you can push back on that extra risk by being thoughtful about your LDL, your blood pressure, your blood sugar, your smoking, your movement, your nutrition, and your stress. For many people with high lipoprotein A, that also means that the potential benefits of statins or other LDL lowering therapies may be larger than they seem if you only look at LDL in isolation. When people are trying to decide about statins, they are usually looking at a few key numbers: their LDL, their HDL, and triglycerides, and maybe their apolipoprotein B. Those numbers can feel abstract, so I want to give you a general map for how they are often interpreted. This is not a substitute for your clinician's judgment, but it can help you understand the conversation. In the United States, LDL is usually reported in milligrams per deciliter. In Canada or the UK and many other countries, it is more commonly to see LDL in millimoles per liter. Most labs still give general categories for LDL. For adults, an LDL below 100, which is about 2.6 millimoles per liter, is often called optimal. From 100 to 129, or about 2.6 to 3.3 millimoles, is often called near optimal or above optimal. From 130 to 159 milligrams per deciliter, which is roughly 3.4 to 4.1 millimoles per liter, that's considered borderline high. From 160 to 189, which translates to 4.1 to 4.9 millimoles per liter, that's considered high. And 190 milligrams per deciliter and above, which is above about 4.9 millimoles per liter, is very high. These numbers are not the full story, but they give a framework for how many labs and clinicians talk about LDL. If you want a consolidated list of these lab values, join up my Patreon membership and find them posted on my feed along with a summary of this video. Guidelines on how to treat then layer risk on top of those categories. For people who already have a clear cardiovascular disease like a heart attack or a stent or bypass surgery or stroke, many expert groups recommend aiming for an LDL below 70 milligrams per deciliter, which is below about 1.8 millimoles per liter. And in very high-risk situations, sometimes closer to lower than 55 milligrams per deciliter, or about 1.4 millimoles per liter. There are also red flag numbers backed by strong evidence. An LDL of 190 milligrams per deciliter or higher, which again is about 4.9 millimoles per liter or higher, is high enough that many guidelines strongly recommend statin therapy because that level is so often linked to genetic causes and a much higher lifetime risk of plaque buildup. In those situations, the focus is less on small lifestyle tweaks and more on getting that LDL down substantially with medication plus lifestyle together. Along with LDL, some of you in higher risk categories might see ApoB on your labs or apolipoprotein B. ApoB is a protein carried on LDL and other plaque promoting particles, so it gives a sense of how many of those particles are circulating in the blood. ApoB is usually reported in milligrams per deciliter or grams per liter. Some guidelines suggest ApoB targets in the range of less than about 65 to 80 for people at higher cardiovascular risk who are already on statins. That is roughly less than 0.65 to 0.8 grams per liter, depending on how your lab reports it. If your lab uses a different unit, you will often see the reference range printed right next to your result, and your clinician or pharmacist can help you interpret it. I have an entire separate video focusing just on ApoB and particle numbers, and I will put a link to that in the video description for anyone who wants to learn more about it. The key idea is that these numbers live on a spectrum. There is no magic cliff where 99 is safe and 101 is dangerous. Lower LDL over the long term generally means less plaque growth and lower risk. And higher LDL over the long term means more plaque growth and higher risk. Knowing the basic ranges makes it easier to ask focused questions at your appointment, such as asking what LDL range you are aiming for. Wondering if you could fix this with just lifestyle alone is a reasonable question to ask. Lifestyle does sit underneath almost everything we are talking about in this video and affects far more than just your LDL. What you eat most of the time, how much you move, how you sleep, how you manage stress, whether you smoke, how much alcohol you drink, and your social environment all feed into blood pressure, blood sugar, weight, inflammation, and other cholesterol patterns. Nutrition is one of the first things doctors talk about, but the way it is presented is often not very helpful. Many people are told a few vague phrases like eat healthier or cut down on saturated fat without any real guidance on what that looks like in everyday meals. From a cholesterol and heart standpoint, the overall pattern matters more than any single food. Diets that emphasize vegetables, fruits, whole grains, beans, lentils, nuts, seeds, and unsaturated fats from foods like olive oil and fatty fish tend to support lower LDL and better overall cardiovascular health. Patterns that lean heavily on ultra-processed foods, refined starches, sugary drinks, saturated fats, and trans fats tend to push things in the opposite direction. For some people, more specific adjustments, such as increasing soluble fiber from oats, beans, and certain fruits, or using plant sterol-enriched foods, can make a noticeable difference in LDL. I do have a guide available that can help you build a heart-healthy diet, and we'll put a link to that in the video description. Movement is also important. You do not have to become an athlete for your heart and cholesterol to benefit. Regular, moderate activity like brisk walking, cycling, swimming, or dancing can improve insulin sensitivity, lower blood pressure, help with weight management, and support healthier triglycerides and HDL. Strength training helps preserve muscle mass, which is important for long-term metabolic health. Just breaking up long periods of sitting with short movement breaks can help a lot. For many people, the biggest barrier is not knowing that exercise is helpful. It is figuring out how to fit realistic movement into a busy, tired, real life. Sleep and stress are often left out of cholesterol conversations, but they also matter. Chronic poor sleep can worsen insulin resistance, increase appetite, and raise blood pressure, all of which feed into higher cardiovascular risk over time. Ongoing stress can change eating patterns, reduce motivation to move more, and keep the nervous system in a more activated state. I'm not saying that one bad night of sleep or one stressful week will damage your arteries, but over years, these patterns can tilt things in the wrong direction. Smoking, if it is part of your life, is a very powerful driver of blood vessel damage. Quitting or even cutting down on the way to quitting is one of the most effective things that you can do to protect your arteries, regardless of what your LDL is doing. Alcohol also plays a role. Regular heavy drinking can raise triglycerides and blood pressure and contribute to weight gain and fatty liver. Light to moderate drinking affects people differently, and recommendations there are becoming more cautious as we learn more about the long-term effects of alcohol. So, what can lifestyle realistically do for LDL itself? For some people, particularly those whose LDL is moderately elevated and who have a lot of room to shift their eating pattern, weight, and activity, changes in lifestyle can bring LDL down by a meaningful amount, sometimes 10 to 20% or more. For others, especially those who have genetics as a strong driver, lifestyle may only nudge LDL a bit, even when they are doing many things right. And that can be frustrating, but it does not mean that lifestyle is pointless. The same changes that only slightly lower LDL on paper may still lower blood pressure, improve blood sugar, reduce inflammation, and support a healthier weight. All of that improves overall risk, even if the LDL number is stubborn. I also want to recognize how hard change is, even when you deeply care about your health. Many people are sent out of the clinic with a list of instructions and almost no support for the day-to-day reality of making new habits stick. If you work shifts or you have chronic pain or you're caring for family or struggle with emotional eating, it is not enough to say eat more fiber and exercise. You need strategies that fit your life, gentle troubleshooting when things do not go as planned, and someone to help you break big goals into manageable steps. This is why I'm building a membership focused on lifestyle support to help you meet your health goals. It's designed to move beyond generic advice and into the practical, sometimes messy process of changing patterns in real life. Lifestyle is not a consolation prize you try before real treatment. It is a central part of cardiovascular prevention at every stage. For some people at lower risk, lifestyle changes may be enough to keep LDL and overall risk in a range where medication is not needed, or at least for now. For people at higher risk, lifestyle and medication often work together. The statin or other therapy lowers LDL more powerfully, while nutrition, movement, sleep, and stress work on the rest of the risk package and help support your overall health and quality of life. When you are weighing the decision about a statin, it can help to think in terms of what is realistically achievable for you with lifestyle in the next 6 to 12 months, and what your numbers and risk look like even with your best sustainable effort. Some people prefer to focus on lifestyle first and revisit medication after a trial period. Others, especially with higher baseline risk, may choose to start a statin while also working on lifestyle, knowing that both are protecting them in different ways. Neither approach is morally better. The key is that you understand the role of lifestyle, have realistic expectations for what it can and cannot do for LDL and risk, and feel supported in whatever changes you are ready to make. Not every elevated LDL automatically means a statin. In thoughtful care, medication comes into the picture when the chance of benefit is high enough that it makes sense to add something on top of lifestyle, or when lifestyle alone is very unlikely to get LDL into a range that matches your overall risk. There are a few situations where statins are recommended very strongly. One is when someone already has clear cardiovascular disease, like a prior heart attack, stent, bypass surgery, stroke, or certain kinds of blocked arteries, like in the legs. In that group, the evidence is very consistent that using a statin to push LDL down by at least about 50% and aiming for levels below 70 milligrams per deciliter, which translates to 1.8 millimoles per liter, lowers the chance of another event. In some very high-risk people, especially in European and newer international guidelines, the LDL goal is even lower, closer to 55 milligrams per deciliter, or about 1.4 millimoles per liter, or lower. Another strong signal is very high LDL with no obvious secondary cause, especially when LDL is 190 milligrams per deciliter or higher, which is about 4.9 millimoles per liter. Levels in that range are often a sign of a genetic tendency towards high cholesterol and a much higher lifetime risk of plaque buildup. For that group, major guidelines recommend starting a high intensity statin or the strongest dose someone can comfortably tolerate without even needing to calculate a 10-year risk because the LDL is so high by itself. The goal is to bring LDL down substantially, ideally by at least 50%, and to below 100 milligrams per deciliter or below 2.6 millimole per liter. And then consider adding other medications if that target is not reached. Diabetes is another situation where you see statins show up more often. For many adults in midlife with diabetes, the risk of cardiovascular disease is high enough that guidelines usually recommend at least a moderate intensity statin, even if LDL is not in an extreme range. If there are additional risk factors on top of diabetes, a higher intensity statin is often suggested to get a larger LDL reduction. Again, lifestyle still matters a lot here, but the baseline risk from diabetes is high enough that medication benefits are clear. For people closer to the situation where they have an LDL that is mildly elevated or even technically near optimal, but they have factors like an elevated lipoprotein A, family history, or high blood pressure, the decision is more individualized. Guidelines generally encourage a statin when the overall risk reaches a certain level, but in this group, there is room for discussion. Some people choose an intensive lifestyle effort first with a plan to repeat labs and reconsider. Others, especially those with a high lipoprotein A or a strong family history of early heart disease, feel more comfortable adding a statin sooner, even when their LDL is under 100, to stack the odds in their favor. When a statin is used, the dose is usually chosen with a rough LDL lowering goal in mind. High-intensity statins, like higher doses of atorvastatin or rosuvastatin, can lower LDL by about 50% or more for many people. Moderate intensity doses usually lower LDL by around 30 to 50%. Those are averages from large studies. In real life, some people see bigger drops and some see smaller. The idea is to move LDL into a range that better matches your overall risk profile. Statins are the backbone of LDL lowering therapy, but they are not the only option. Ezetimibe, also called Zetia, is an oral medication that reduces cholesterol absorption in the gut and can lower LDL by an additional 15 to 25% on top of a statin in many cases. PCSK9 inhibitors like Repatha, Leqvio, and Praluent are injectable medications given every 2 to 4 weeks that can lower LDL dramatically, often by 50 to 60% on top of statins. And they are usually reserved for people at very high risk or with genetic cholesterol disorders who do not reach goals with statins alone. They are also used for people who do not tolerate statin therapy. PCSK9 inhibitors have also been shown to lower lipoprotein A, but they are not approved for this. It is more like a side effect. There is an oral PCSK9 inhibitor currently in development. There is a newer medication called bempedoic acid, which is a pill that offers one more way to lower LDL for people who cannot tolerate statins well or need extra help to get LDL into target ranges. In practical terms, this usually shows up as a sequence. A doctor might start with a moderate or high intensity statin and see how your LDL responds. If your LDL does not come down as much as hoped, or if you were in a very high risk group and still above the recommended thresholds, adding ezetimibe is a common next step. If someone remains above target despite those steps and has very high risk or genetic conditions, a PCSK9 inhibitor or other advanced therapies may be considered. Not everyone needs that full escalation, but it is helpful to know that these tools exist, especially if your LDL remains high despite good adherence to lifestyle and medication. For people with mildly elevated LDL and no clear high risk features, there is more flexibility. Some will reasonably choose to focus on lifestyle first, especially if they feel strongly about avoiding medication and their doctor agrees that their current risk is not extremely high. Others, particularly those with an elevated lipoprotein A or a worrisome family history, may decide that a lower moderate dose of a statin feels like a worthwhile added layer of protection while they also work on lifestyle. In both scenarios, it is not an all or nothing judgment about being healthy enough to avoid medication. It is a choice about how many tools you want to use given your specific risk picture. Medication should not be seen as a punishment for doing lifestyle wrong, and lifestyle is not a substitute for appropriate medication in people whose risk is clearly high. They are different tools that can be combined in different ways. Understanding when and why statins and other LDL lowering therapies are recommended can help you look at your own numbers and your own situation and see whether you are in a range where a statin is clearly indicated, or clearly not needed, or in that middle space where a careful, personalized discussion makes the most sense. Statins work mainly at the level of the liver. Your liver is constantly making cholesterol and packaging it into particles like LDL to send out into the bloodstream. Statins block a key enzyme that the liver uses to produce cholesterol. When that enzyme is partially blocked, the liver makes less cholesterol and responds by pulling more LDL particles out of the blood. The end result for most people is a significant drop in LDL over the next several weeks to months. That drop in LDL is not just nice to see on a lab report. Over many large clinical trials, people at higher cardiovascular risk who lower their LDL with statins have fewer heart attacks, fewer strokes, and are less likely to need procedures like stents and bypass surgery. The higher the baseline risk and the larger the LDL reduction, the bigger the benefit tends to be. When you hear about high-intensity statins, that is really just shorthand for doses that, on average, lower LDL by around 50% or more. And that level of lowering has been linked with meaningful reductions in events for people who start out at higher risk. One thing that can be frustrating is the time frame. You do not feel a statin working the way that you might feel a pain medication or a decongestant. The benefits are about changing the odds over years, not days. As LDL stays lower over time, plaque growth tends to slow, and plaques are more likely to stabilize. That is why the decision to start, continue, or stop a statin is really a decision about long-term prevention. It is about where you want your risk to be in 5, 10, or 15 years, and what tools you are willing to use to move that risk in a direction that fits your health goals. When people hesitate about statins, it is almost never just about the idea of taking a pill. It is usually about the fear of side effects. You might have heard stories of terrible muscle pain, damaged livers, diabetes, brain fog, or even dementia. Some of those concerns are based on a tiny kernel of truth that has been stretched far beyond what the evidence supports. Others come from personal experiences that are very real to that person, but not really generalizable to everyone else or are always caused by the statin itself. The most common concern is muscle pain. Many people have heard that statins ruin your muscles or cause constant aches. In clinical trials where people did not know if they were getting a statin or a placebo, the overall rates of muscle aches were almost the same in both groups. Only a small fraction of muscle symptoms can clearly be blamed on the statin itself. It is true that statin-related muscle pain does happen, but it is much less common than you might think. And when it does occur, it is usually mild and reversible. Serious muscle injury does happen, but it is extremely rare and only occurs in around 1 in 10,000 people per year. And it is much more likely when very high doses are combined with certain interacting medications or kidney problems. Liver concerns are another big fear Statins do act in the liver, and a small percentage of people will see a mild bump in liver enzymes on blood tests. In the vast majority of cases, those enzyme changes are small, cause no symptoms, and return to normal if the dose is lowered or the drug is stopped. Serious liver injury from statins is extraordinarily rare, on the order of about 1 in 100,000 people. Large trials have not shown higher rates of liver failure in statin groups compared with placebo. For most people with a healthy liver to begin with, statins are considered very safe from a liver standpoint. Your doctor will usually check liver enzymes when you start therapy and may recheck if you ever develop symptoms like dark urine or yellowing of the skin. But ongoing liver damage from statins is not something most patients need to worry about. Blood sugar and diabetes risk comes up a lot as well. Statins can slightly nudge blood sugar upward in some people, especially those who already have prediabetes or other risk factors. In big trials, that translates to a small increase in the number of people diagnosed with diabetes over several years, often in people who are already on the path toward diabetes. At the same time, those same studies show that statins prevent many more heart attacks and strokes than the small number of extra diabetes diagnoses they are associated with. For someone at meaningful cardiovascular risk, the reduction in heart events generally outweighs the modest change in blood sugar. If you already have prediabetes, it is reasonable for your clinician to monitor your A1C and fasting glucose a bit more closely and to keep emphasizing lifestyle. But the presence of that small diabetes signal is not a reason by itself to avoid statins in people who stand to benefit. Cognitive effects in memory are another area where anxiety is common. There have been individual reports of brain fog or forgetfulness in people taking statins, and years ago that led to language on labels mentioning possible memory issues. When researchers have looked at this carefully in large studies, they have not found evidence that statins cause dementia or significant long-term cognitive decline. In randomized trials, people on statins perform about the same on memory and thinking tests as those on placebo. And some observational studies even suggest a slightly lower risk of dementia in statin users, likely because of fewer strokes and better vascular health in the brain. If someone on a statin feels like their memory has changed, it is reasonable to talk with their doctor, and sometimes a trial off the medication can help sort out what is going on. But the current weight of evidence does not support the idea that statins are broadly harmful to the brain. Beyond those areas, many other fears have been raised over the years, like cancer, cataracts, severe weakness, sexual dysfunction. Long-term data involving hundreds of thousands of people have not shown convincing links between statins and those problems. Overall cancer rates are not higher in statin groups. There is no strong evidence that statins cause cataracts or widespread muscle failure. Some studies even suggest better erectile function in some men, likely because of improved blood flow. That does not mean that statins are completely side effect free. It does mean that many of the scariest stories circulating online do not match what we see in careful long-term research. If you start a statin and notice that something feels off, this is where partnership with your clinician really matters. Instead of silently stopping the medication or pushing through in misery, bring the symptoms to your next visit or call sooner if they are significant. Often the first step is simply to pause the statin for a few weeks and see if symptoms settle down. If they do, you can try restarting at a lower dose or switching to a different statin. Some people tolerate one statin poorly, but do very well on another. Others do best with a small dose taken every other day or a few times per week. For many people, this kind of trial and error leads to a regimen that gives the heart protection of a statin with little or no ongoing discomfort. Supplements like coenzyme Q10 are sometimes tried, though evidence is limited. Checking and correcting things like vitamin D deficiency or thyroid issues can also help when muscle symptoms are present. A very small group of people will truly not tolerate any meaningful dose of a statin, even after trying multiple types and dosing strategies. For them, other medications can play a larger role. The important point is that being sensitive to one statin or one dose does not automatically mean all statins are off the table forever. Most people with some patience and adjustments can find a way to benefit from statin therapy if their risk profile suggests that it is worthwhile. The big picture from decades of research is that statins are generally well tolerated. Serious side effects are rare, and for people at moderate to high cardiovascular risk, the benefits in preventing heart attacks and strokes are much larger than the risk of side effects. That does not erase anyone's individual experience, and it does not mean that you need to ignore your body. It means that fear alone, especially fear based on dramatic stories or headlines, is not a great guide for making this decision. A better guide is your actual risk, your actual response to medication, and an open line of communication with your care team about how you feel on treatment. Even with everything we know about LDL and heart risk, many people walk around with LDL levels that are higher than ideal for their situation, and no one has really addressed it with them. Some have already had a heart attack or stent and still have LDL that is not in the range recommended by guidelines. Others have clear risk factors like diabetes, high blood pressure, or an elevated lipoprotein A, and LDL that is okay on paper, but not low enough given the rest of their profile. Studies looking at real world practice keep finding the same pattern. A large number of people who would qualify for statins based on their risk are not on them at all. Among those who are, many are not on doses strong enough to bring LDL into the ranges that evidence suggests would protect them the best. It is not that clinicians do not care about prevention, but busy systems, short visits, and competing demands mean that cholesterol can quietly slide down the priority list, especially if the person is feeling well and there is no crisis in the present. There are several reasons that this happens. Primary care visits are often squeezed into 10 or 15 minutes. In that time, doctors are expected to address multiple chronic conditions, new symptoms, refills, mental health, social issues, and paperwork. When there is chest pain or uncontrolled blood sugar or a new diagnosis to discuss, a lab line showing an LDL of 120 or 140 might not get much attention, even if it does deserve follow-up. Knowledge gaps also play a role. Guidelines evolve, and not everyone stays fully up to date. Some doctors are less familiar with newer LDL targets for very high risk patients, or with how strongly things like lipoprotein A or chronic kidney disease should influence LDL goals. Others may be hesitant to intensify statins or add another LDL lowering medication because they worry about side effects, or they assume that the person in front of them would not want more medication. These assumptions are not always checked with the patient, so the conversation never really happens. On the patient side, many people assume that if something on their lab report was important, their doctor would bring it up. If no one mentions LDL, they assume that it must be fine. Sometimes people are told once that their cholesterol is a little high and then hear nothing more for years to come. So they come to believe that it cannot be very important. Others have brought up concerns about statins before and felt dismissed. Maybe they were quickly handed a prescription without discussion, or their worries about side effects were brushed off. After that, they may be less likely to ask again, even as their risk slowly rises. All of this leads to missed opportunities. LDL stays higher than it needs to be. People at meaningful risk are not offered treatments that could lower their chances of heart attack or stroke. People who are already taking statins but not at doses that match their risk never have a chance to talk about whether a stronger dose or an additional medication might be right for them. Unfortunately, the system often does not support the kind of slow, careful prevention work that LDL management really requires. Knowing that undertreatment is common can actually empower you. If you have had a heart event, or if you know you're at a higher risk and you see an LDL that looks higher than the targets we talked about earlier, you do not have to wait passively for someone to bring it up. You are allowed to say, I see my LDL is still at this level. Given my history, should we be aiming lower? Or are there other options to help bring this down more? That kind of question is not being a difficult patient. It is advocating for yourself. It is simply asking for your care to match what we know from the research about how LDL management can protect people over the long term. Many people who feel uneasy about their LDL never quite get around to bringing it up in their next doctor visit. It can feel intimidating to raise the topic, especially if previous attempts led to a quick prescription with little explanation, or, on the other hand, a quick dismissal of your concerns. A simple starting point is to state your intention, saying something like, I'd like to talk about my cholesterol and my long term health heart risk today. Tells your doctor that this is important to you. Clinicians juggle a lot in a short visit, and sometimes just hearing that sentence helps them prioritize the conversation. Having your latest lab results in front of you, either on paper or in a portal app, makes it easier to stay grounded in specific numbers rather than vague impressions. Sharing what you already understand and where you feel unsure can also help. For example, you might say, I see that my LDL is around this level, and I know I have lipoprotein A and high blood pressure. I'm trying to understand how all of that fits together and what LDL range makes sense as a goal for me. That kind of statement tells your doctor you have done your homework and invites them to fill in the missing pieces rather than starting from scratch or assuming you do not want the details. Clear questions keep the conversation focused. Many people find it useful to ask things like what LDL range that they are aiming for, or given their history, if the doctor thinks that they're in a group that usually benefits from a statin. It can also be helpful to ask if you work on lifestyle for a few months, what kind of change in your numbers would make the doctor feel comfortable holding off on a medication, and what would make them lean towards starting one. This gives you a shared target and a plan instead of a vague sense of try harder and we'll see. If you have concerns about statins, naming them up front can prevent misunderstandings later. Saying, I'm open to medication, but I am worried about muscle aches and brain fog because of things I have heard, is more helpful than a flat, I don't want statins. It gives your doctor a chance to share what the evidence shows, talk through side effects rates, and suggest a cautious approach if you decide to try one. Maybe like starting with a lower dose or choosing a statin with a good tolerability record and planning a follow up to check in on how you feel. Sometimes the barrier is not fear of the medication, but fear of feeling dismissed. If you have felt rushed or brushed off in the past, it is okay to be honest about that in a calm way. For example, you can mention that in previous visits you felt like your cholesterol was either minimized or you were just handed a prescription and that you are really hoping the doctor can slow down a little bit and make a plan together with you this time. Most doctors genuinely want to help and may not realize how their style came across before. Framing it as a request for partnership, not an attack, can shift the tone of the visit. Support can make these conversations easier. Writing down your main points ahead of time, or bring in a family member or friend if that feels supportive, or even rehearsing a few sentences out loud can reduce the pressure in the moment. If you leave the appointment still feeling unclear about why a statin was recommended or not recommended, it is okay to say that you are still not sure that you understand and ask for a summary of the main reasons for the recommendation so you can think about it. You deserve to walk away knowing what your options are and why your doctor leans the way they do. All this can still feel like a lot to sort through when you are sitting with a lab report in front of you or a new prescription in your hand. Pulling this together into a simple framework can make the decision feel more manageable. One helpful way to think about it is in layers. The first layer is your underlying risk. This includes your age, your sex, your blood pressure, blood sugar, smoking status, family history, lipoprotein A, and any history of cardiovascular disease. That layer is there whether you take a statin or not. Some parts of it are changeable, like smoking and blood pressure, Other parts like age and genetics are not. Understanding this layer means being honest about where you are starting from without blame and without minimizing. The second layer is your LDL and other cholesterol related markers, including ApoB when that has been measured. These numbers tell you something about how many plaque promoting particles your arteries are exposed to over time. Lowering LDL reduces that exposure and in higher risk groups has consistently translated into fewer heart events over the years. For someone with a higher lipoprotein A, LDL, and ApoB, take on even more weight because they are factors that you can actually move to counterbalance risk that comes bundled into your genes. The third layer is lifestyle. This covers your way of eating, how much you move, your sleep, how you handle stress, and your relationships with things like tobacco and alcohol. Lifestyle shapes almost every other risk factor. For some people, it can move LDL and overall risk by a large amount. For others, especially when genetics are strong, it may only make a modest difference in LDL, even with a lot of effort. Either way, it matters for your heart, your blood vessels, and the rest of your body. It also has to be realistic and sustainable for the life you actually live. The fourth layer is medication. Medications are tools that can lower LDL more powerfully and more predictably than lifestyle alone, especially when risk is already elevated. They do not replace lifestyle, and lifestyle does not take away their potential benefits in higher risk situations. Medications do come with potential side effects, but for many people at moderate to high cardiovascular risk, the reduction in heart attacks and strokes is larger than the extra risk of those side effects. The point is not to see medication as a judgment about how healthy you are. It is simply one more tool that can be included or not included in your overall plan. Once these layers are clear, the statin decision becomes a matter of alignment. For someone with very high risk, such as a previous heart attack, a very high LDL, or high lipoprotein A, plus multiple other risk factors, using a statin is usually a strong recommendation because the potential benefit is large. In that setting, the focus is often on which statin, at what intensity, and how to combine it with lifestyle changes. For someone at lower risk with only mild LDL elevation, there is usually more flexibility. It can be reasonable to focus on lifestyle first with a plan to repeat labs after a defined period and then revisit the question. It can also be reasonable to choose a low or moderate dose statin earlier if that feels like a comfortable way to lower risk while lifestyle changes are taking shape. Both paths can be valid depending on risk and personal preference. Many people land in a middle zone and feel pulled in both directions. They are worried about heart disease and also worried about medication. It helps to recognize that mixed feeling instead of pushing it away. From there, it often works better to think in terms of trying an approach, gathering more information and adjusting, rather than treating this as a one-time permanent decision about your identity as someone who does or does not take statins. Time-limited experiments can be useful. Some people agree with their doctor on a period of focused lifestyle effort with specific changes and a clear plan to recheck LDL. Others agree to try a statin at a certain dose with scheduled follow-up to check labs and talk about how they are feeling, knowing that the plan can be modified if needed. Approaches like this respect both the science and your need to feel involved and heard. Support makes all of this easier. Changing lifestyle patterns, dealing with health anxiety, and managing medications are hard to do alone. This is a big reason I am building a membership program focused on lifestyle support and education to help you meet your health goals. The aim is to help with the practical, everyday side of change so that you are not carrying all of that by yourself. If you are interested in learning more, I will put a link below so you can sign up for that mailing list. You deserve to make this decision from a place of information and self-respect, not panic or pressure. LDL, lipoprotein A, statins, and lifestyle are all parts of the same bigger goal, keeping you as healthy and functional as possible for as long as possible, and a life that still feels like your own. My hope is that this video has given you tools to understand your labs, understand your options, and sit down with your doctor to make a plan that fits where you are right now. If it did, please give this long video a like so I know that it was helpful. And subscribe for more science-based content on how to manage your risk so you can live a healthier, longer life. I have a lot of good content planned, including if supplements can play a role in lowering LDL. So hit that notification bell if you don't want to miss that. Thank you so much for watching. And as always, please take good care of yourself.